Now we'll lead to the next presentation, excuse me, is from Sean Hocking and Ruth Glew on psychosocial care for people with MND.
Thank you for the invitation to speak to you today about the work we've been doing in South Wales, UK, to develop a psychological model of care. It will be fascinating learning from other services across the world and sharing, no doubt, similar experiences of working with patients with MND and their families. In this 15-minute presentation, I hope to share something about the rationale for a psychological model to be embedded within services. This will include exploring the psychological needs of patients, families, and staff working alongside them. I will also highlight the risks associated with not having a psychological model of care within services. And finally, we'll share something of our experience developing a psychological model of care here in South Wales. So a little bit about the context of motor neuron disease in South Wales. So care is organised for the patient group by the South Wales MND Care Network, which is a network of healthcare professionals who organise multidisciplinary care and support for people with motor neuron disease and their families across Wales. The network receives between 90 and 100 referrals a year, and across the network there are around 185 patients at any one time. The network works in partnership with the Motor Neuron Disease Association, who jointly fund the network alongside local NHS health boards. During the COVID pandemic, the network has embraced change in quite remarkable ways to continue to provide a service for people with motor neuron disease and their families. This has involved providing virtual clinics in place of face-to-face clinics, remote team meetings, and for many of the team care coordinators, they're providing much of their coordination from their home. Just at the bottom of the screen there, you'll see a photo of us just last year winning an NHS award here in Wales for partnership working across all of the different health boards and working with charitable organisations like the Motor Neuron Disease Association. So before we consider the model of psychological care, let's consider what the needs are within MND services. The research literature suggests three areas of need: thinking about patients who are living with MND, families and carers, and then staff. The diagnosis of MND has a significant and devastating psychological impact for patients, including coping with the diagnosis, adjustment, understanding the condition, perhaps for many of the patients who are diagnosed, a sense of a loss of role, the loss of an expected future, perhaps the loss of physical mobility or speech, changes within relationships, and then needing to make decisions about care. In addition to the psychological sequelae associated with the diagnosis, cognitive and behavioural changes occur in approximately 50% of patients with MND, requiring neuropsychological assessment and intervention in many cases. Families and carers also present commonly with specific psychological needs relating to issues such as adjustment to the diagnosis, loss of future plans, loss of their role, changes within the relationship, and changes within the family dynamic. We know in Wales that around 76% of carers during the COVID pandemic reported feeling burnt out and exhausted by all the pressure that was on them and the increased need that they were having to deal with. The other area of need is around staff. The staff who work with patients and families also communicate a need for greater psychological competence and opportunities for reflective practice and clinical supervision around complex case management, including team psychological formulation. A further need for staff is around neuropsychological competence, with many staff trained to administer cognitive screening tools such as the ECAS, the Edinburgh Cognitive ALS Scale, but requiring supervision to support with the interpretation of results and the application of what this means for the patient, as well as then being able to access further neuropsychological assessment if indicated. In South Wales, several factors led to the development of the psychological care model. A transforming care audit suggested locally that psychological care was a significant area of unmet need not previously provided by the service. Research evidence suggests that psychological care should be integrated with physical care in an organised, systematic and practical way. It may well surprise you that mental health significantly impacts patients' quality of life more so than physical comorbidities. And local guidance here in Wales, in the UK, for example, No Health Without Mental Health, really reflect those findings. A key consideration was to follow best practice guidelines and develop a model that would be sustainable and equitable across South Wales and offered parity with other neurological conditions and between physical and mental health. What is very clear is that this should be a biopsychosocial approach in terms of managing the overall care of patients with MND. And this was something that here in South Wales hadn't happened yet. It has been vital not just to explain to commissioners about the benefits of providing psychological care, but also the risks of not providing this. Some of the risks are listed here: poor health outcomes for patients with psychological care not being integrated alongside their physical care, limited access to neuropsychological assessment and intervention that would inform care and treatment options, lack of adherence to the National Institute for Clinical and Health Excellence guidelines here in the UK around neuropsychological assessment more specifically, increased risk of hospital admission and therefore the poor use of financial resources as a consequence. And as I mentioned, an increased risk of carer burnout leading to poor health outcomes for many carers. So funding was received by the Motor Neuron Disease Association with the aim of designing and developing an innovative model of psychological care that was equitable and sustainable. I was brought into post for 1 day a week at the end of 2018 and began by completing a service evaluation of the 12 clinics that are run across the network to evaluate the psychological needs of patients and their families. And results were consistent with the empirical literature, which suggests a very high level of need, approximately 40% in both patients and family members here in South Wales. The data also indicated that there were specific points in the patient journey where psychological need was most salient. So in our patients, that tended to be around the 0 to 6 months after diagnosis. It seems that some of the psychological work at this point needed to be around adjusting to diagnosis and perhaps making treatment decisions and decisions about the future. A staff audit was also conducted with the MND care coordinators who interface with psychological distress very often. So they communicated a lack of confidence in their skills to manage some of this distress and felt like the existing unmet psychological need impacted negatively on their workload. Many of the care coordinators reported increased calls from family members and patients, and just those people being unable to manage their own anxiety. So moving on to the model. The model is based on a visible healthcare psychological model designed by Dr. Richard Cudahy in South Wales, and it incorporates many of the roles that psychologists play within healthcare teams. It includes a focus around staff, the work that needs to be done with staff, as well as some of the clinical tasks, and presents a tiered approach to psychological care, which is integrated throughout the service. The work with staff is around psychological and neuropsychological skills assessment and training, as you can see in the far left box there. supervision of cognitive assessment, and supervision of those who are using psychological approaches. Care coordinators have access to clinical supervision and are able to bring complex cases to discussion, and we use psychological models to really think through their approach. And there's also something around consultation, around complex case management and promotion of staff well-being. We know that it's particularly challenging to work with this patient group, managing patient deaths regularly, managing high levels of emotion and distress, and it's important for staff to have opportunity to reflect on what the impact of that is on them. The clinical tasks when it comes to patients and staff are very much kind of aligned. But with patients and families, the tasks tend to be around, as I mentioned, adjustment to diagnosis, understanding and acceptance of the disease, often in order to be able to make treatment decisions. So, for example, readiness to have a PEG insertion, readiness to have some other form of treatment, and thinking about the future. Managing changes in cognition, changes within relationships and the roles of individuals, decision-making, and then coping with death. And so how we've structured our psychological model is in a tiered approach. So at the bottom, we have more of a psychoeducational component where psychological information is disseminated via leaflets and written information that we have access to. On that next level then is group psychological intervention, and this is something that we have yet to develop actually in South Wales, but our hope is to run an acceptance and commitment therapy group with patients and caregivers as well. One of the things that it's quite a new initiative in South Wales is to run a newly diagnosed day, and we have input of psychologists in that as well. So increasing to more of the specialist aspects of the psychological role. So that would include individual one-to-one psychological therapy. Often this would be using an ACT approach, and that might be with the patient themselves or with families or actually together. Also within that would be individual neuropsychological assessment and formulation. And then right at the top of that triangle is the really specialist areas for psychologists around consultation, team formulation, and staff supervision. And the hope is that by implementing psychology at each of these different stages, then psychological care becomes very much integrated alongside physical care. And by having a psychologist in post, by having a psychological model, that the competence of the overall team increases by each of these areas being there. There's also a pathway focus in that we are very aware of different points in the pathway where psychological need might be greater, as I mentioned, at the point of diagnosis and end of life care. But thinking about the need at each of those stages. And of course, we work very closely with partner services such as palliative care and with charities as well, like the Motor Neuron Disease Association. So what are the ways forward for us? So I think we've very much, we're really in the beginnings of developing this model. And as yet, our resource is quite small. We have one psychologist 1 day a week to cover several patients, 185 patients at any one time. So our hope would be to increase the financial resource so that we can really fund the full model of care across South Wales. So that would include then group psychological interventions at Tier 2. The hope is that we can continue to develop our cognitive pathway for patients, with screening offered to all patients at the point of diagnosis, and then opportunities for reassessment there to be in place. And for us here in South Wales, a continued challenge really is to think about our geographic patch. So patients who live kind of in more accessible areas receive the same service that somebody in a less accessible area would receive. and parity across neurological conditions. So thanks very much for listening to this presentation today. If there are any questions, please feel free to ask them now or to get in contact with me after the conference. Many thanks.
Again, I always think there should be applause afterwards, since we're not in a big warm group together. Thank you so much. That was really interesting. You don't know, but during our alliance meetings, just in the past few days, we have also looked at the patient journey, and adding the psychological or mental health piece to the multidisciplinary clinic has been brought up at the association level as well. So that's really, really great to hear this presentation and know that about what's happening in your area of the world. So let's see if there's any questions. People are definitely saying thank you, and that is, great to hear about that there is a psychological care. It's much better than hearing just the deal with it. There are questions on the slides that I am trying to find the answer out to about sharing the slides. So I'll have a question then while we wait to see. You mentioned about how they're doing it now. Is it through the care managers directly? Like, do you speak directly with the whole team? Do you come into the clinic? I wasn't quite sure how that worked.
Okay, is my mic on?
Yes. Mm-hmm.
Great. Yeah, so right back at the beginning, what I did to scope to do the service evaluation is I went along to each of the clinics. Obviously, I'm 1 day a week, so keeping that up in each of the 12 clinics would be probably too much. So that model really demonstrates how we've tried to use the resource to be able to get psychological care throughout the entire network. So we have 4 care coordinators, as well as Ruth, who's the lead care coordinator, who attend clinical supervision and do very much that frontline psychological work with patients and families. And then really it's for them then to come and say, this person may need a little bit more, this relative may need a little bit more. Sometimes we would have more of a formulation approach to that, and sometimes I would then see them individually. Does that answer your question?
Oh, absolutely. Yes. Yes. And if, say, a physical therapist was in the home or saw somebody and saw an acute need, would they be able to, do they go to the care manager then, or do they go directly to you?
Yeah, so the function of the care coordinator really is to hold all of the care. So often the care coordinator is that first port of call really in managing any psychological issues, and then anything that needed disseminating and coming back to me then would kind of filter through the care coordinator.
Yes. Mm-hmm.
But we've got some really skilled coordinators in terms of managing the physical and psychological needs of patients. We're very lucky here.
Yes, yes. The multidisciplinary team clinic is, as many people are aware, a key piece to the care and keeping of people living with ALS MND, but unfortunately across the globe, not everyone has that capability. Now there is a question from ALS Belgium. How, Dirk de Valk, how important is contact between peer ALS patients as compared to contact between an individual patient with a professional psychologist?
It's a really important question. I think when we were running our clinic, sometimes what we found is that patients might bump into each other and might talk to each other, but often, especially in the context of the coronavirus and doing a lot of our work virtually, I think it's impossible often for patients to connect in a physical way with other patients. I think it's really important. And what we found when we were doing our service evaluation was that some of the patients were often kind of put with other patients in a palliative care cohort where they didn't really feel like some of the things that they were struggling with met and matched with some of the other patients who are in that group. So I think the specific needs of patients with MND really need to be considered, and they need opportunity to be able to meet with others. Ruth, I don't know whether you'd like to talk about that at all.
Ruth, I can't hear you. Can other people hear Ruth?
Right.
No.
There you go.
So I think we work very closely with the MND Association, who provides some sort of group support to patients, but also that was part of our new function of our newly diagnosed days, was to actually give newly diagnosed patients an opportunity to meet each other and establish those relationships to support each other. And that actually was really helpful with the one day that we ran as a pilot.
Okay. Despite my usual ability to keep track of time, I'm struggling in the technical realm. Rachel, do you have any idea how long we still have for questions?
I was just looking, actually, the next presentation starts at 7:55. It's well, 55 to,
Oh.
and it's 22 now, so you have time.
Well, I know we're, yeah, I think we're, each person only has, they have the 20 minutes though, so that's what.
Yeah.
Hey. Yes, so I think we're going to go on to the next presenter now, and we will work out that glitch for the next one. And I also will find out the answer. People are asking about the slides because it is difficult to read them on this type of presentation, and we will have that answer following the next one. Thank you very much again.
Thank you.